Our next update is a COVID update. It's a part of our periodic update to you as the board and to the public. And we are going to be starting with Dr. James Worsley, the Deputy County Administrator, followed by Dr. Samuel, the Director of the Health District. Both of those people are virtual as part of this presentation, and we have them hooked up. But we will be closing with Chief Loy Center, who you know is present in the audience. And so that's sort of been our COVID team, if you will, from the different vantage points that they have. So I'll first turn it over to Dr. Worsley.
Good evening. Thank you for having me. Good evening, Mr. Chair, members of the board, and Dr. Casey. Thank you so much for allowing us to present virtually tonight. It's ironic we're talking about COVID, and COVID has certainly hit my home, so I'm thankful for the technology that we have to be able to present virtually on tonight. And as you said, we will have Dr. Samuel here with me as well in a virtual format, and Chief Center is in the audience. Next slide, please. Go ahead and thank Dave in advance for clicking the slides for us tonight. We certainly appreciate you. So regarding the overview, we're going to have a general update regarding COVID that I will be presenting on the first leg. And then Dr. Samuel is going to come forward and talk a little bit more about BDH Chesterfield Health District updates as it relates to some of the things related to Omicron and the like. Chief Center is going to come and talk more about Fire EMS community update as it relates to those various departments in our community. Next slide, please. We have been very fortunate in Chesterfield County to have a new COVID-19 testing center that is now operating over at the Chesterfield Fairgrounds by the Chesterfield Health District. It started on January the 19th of this year, and they are offering free PCR testing for COVID-19 for ages 3 and older, and it is operated by appointment only. As you can see, there is a link listed here on the screen on this particular slide. Operational hours are Monday through Thursday, 9 to 6. I do want to compliment Dr. Samuel and his team at this location for a well-run operations. This is a live picture of this particular slide that was actually taken this past Monday. I can personally attest that I am very impressed with the operations and the professionalism that is at this location. And it's a quick turnaround. PCR tests there are typically 3 to 4 days to get your results. I can say that they had results back in about 2 days. Next slide, please. In addition to the location I previously mentioned, additional free PCR testing opportunities can be found also in the community. If you are looking at a need for PCR tests in order to check for COVID, you can check out New Deliverance Evangelistic Church over on Turner Road, also the Faith and Family Church Community Center on Worsley Boulevard. Both of those are walk-up only. No appointments are necessary, and the testing is free. In addition to that, there's the website to find out about other dates and times in the community for sites as well. Next slide, please. Recently, you have heard from the federal government in regards to get your free at-home COVID tests that launched early last Monday, January the 17th. So I'm sure many have ordered those particular tests. Those are rapid antigen at-home tests that are not PCR. They can be taken anywhere according to the directions that are provided on the website. But if you have not had the opportunity to order them, there's a link at the bottom of this slide that tells you, well, it's actually the link is called COVIDtests.gov. So you can go to the website, COVIDtests.gov, and order your at-home test. And it's my understanding, based on what I have read and research, that it takes perhaps the end of January, which we are approaching, to the beginning of February, where we'll start seeing those particular at-home tests being delivered out in our mailboxes. So more to come. Hopefully we will see them in the near future in our mailboxes. Next slide, please. I would like to thank the Chesterfield County Libraries and the staff there under the direction of Dr. Michael Mabe and his great staff. We've had the opportunity to partner with VDH in the past, and during the time period of November the 17th, 2021 through January the 6th, 2022, our libraries distribute 11,232 free COVID-19 rapid test kits to Chesterfield County residents and those individuals that needed our assistance. So that is a tremendous help for our county. And I would also like to add that Chesterfield County, we are currently working with the libraries to distribute additional at-home COVID-19 rapid test kits within the next week or so. So more information will be coming out about that very soon. However, I've took the liberty to kind of look at Amazon as well. I know there are several folks that go on Amazon for their shopping, and I was curious, along with others, wanted to know, well, if someone needed a rapid test and wanted to order from Amazon, what is the price and what was the duration or delivery time, estimated delivery time. The pricing for a COVID-19 rapid test kit on Amazon is about $20 for a box of 2 rapid tests, and it takes about 5 to 7 days to get delivered, based on what I found. Next slide, please. You may have also heard regarding Chesterfield County Schools, the 5 to 12K test to stay. This is a concept to allow children who are not fully vaccinated an opportunity to stay in school during their quarantine period in order to meet certain criteria. Chesterfield County Public Schools, according to the information that we received, signed up for this particular program. And so more information is yet to be given, and we're expecting more information to be coming soon about that. So more to come about that as well. Next slide, please. You may have heard also regarding Chesterfield County Public Schools at their board meeting on yesterday, their special call meeting, January 25th, regarding the governor's executive order number 2. Chesterfield County has decided that they are going to rescind the mask mandate. So individuals, parents will have an opportunity to send their children to school without wearing masks. And so this goes into effect January 27th, which is tomorrow. So again, parents have the opportunity to have a choice whether they will send their child to school with or without a mask. Next slide, please. The next few slides are going to cover a few things that are coming out of the governor's office that you may not be aware of. Regarding the governor's COVID action plan, there are 3 main points that are in this action plan that I want to make sure we highlight. One, it provides the COVID-19 vaccine plan for Virginia. It also expands healthcare flexibility, support, and treatment. And then the third point, it prioritizes testing guidelines. Next slide, please. Regarding the vaccine action plan itself, there are 5 points here that gives directions to Secretary of Health and Human Resources to reprioritize resources towards vaccine education and outreach. It also provides to host 120 COVID-19 vaccine events across the Commonwealth, and it directs the Secretary of Health and Human Services to devote additional resources to the future events. And next slide, please. The next 3 points provide additional COVID action points here. Number 3, it deploys an opportunity for mobile vaccine units to move towards rural communities. The 4th point, it gives the opportunity working with governors across the country to identify and utilize best practices regarding vaccine education. And it also provides an opportunity to empower Virginians with choices and not mandates according to the action plan regarding vaccines. Next slide, please. Also out of the governor's office, you may be familiar with the governor's executive order number 11. This executive order gives healthcare providers flexibility and support to battle staffing shortages regarding COVID-19 pandemic. And to give you just 2 examples in this category, so you can have an idea of what kind of flexibility they're talking about. One would be, an example would be allowing hospitals and nursing homes to rapidly expand bed capacity by temporarily waiving regulations. Another example would be providing flexibility for licensed out-of-state nurses and healthcare professionals to practice in Virginia. Those are just 2 examples that you can find in this particular executive order. Next slide, please. Regarding the governor's prioritized testing guidelines, there are at least 3 points here where it directs the Secretary of Health and Human Resources to expedite pending orders of rapid tests and to work with the White House to speed up distribution of tests to Virginia localities. It also redeploys unused tests to state agencies. And then thirdly, it directs the state health commissioner to issue new guidelines that prioritize the use of rapid tests for key categories. Next slide, please. We've talked about some local and some state information. This slide is focused on a federal rule. This from Centers for Medicare and Medicaid Services. This is a federal rule. The Centers for Medicare and Medicaid Services, known as CMS, is part of the United States Department of Health and Human Services. It requires state Medicare and Medicaid certified providers and suppliers to ensure that all their applicable staff are vaccinated for COVID-19. What does that mean for Chesterfield County? Well, we have some areas in Chesterfield County, particularly in the Mental Health Support Services Department, where we have staff that meets this requirement. And I am thankful to say that Director Kelly Freed, our County Attorney's Office, our Human Resources Department, as well as our Risk Management Department, have worked over the last few months, actually, to pull together the CMS vaccine requirement policy and procedures so that we can ensure that we have our staff in compliance, particularly at the intensive care facilities known as ICF. And you may know them as also as Galloway Place and Pine Forest. So our staff that work in these particular locations, intensive care facilities, will be meeting that particular CMS rule that we have to meet according to the federal government. Next slide, please. And the last thing I always like to put back up into the front for is that you have the opportunity to visit Chesterfield.gov/COVID. If you need any information about other locations regarding COVID tests, testing sites, or how to get the vaccine, you go here and we have a plethora of opportunities for you to learn a little bit more. Next up on our presentation this evening will be Dr. Alexander Samuel, who is also joining us virtually. Dr. Samuel.
Thank you, Dr. Worsley.
Good evening. Next slide, please. Mr. Chair, members of the board, Dr. Casey, I'm pleased to be part of this great team providing you a COVID update for Chesterfield County. I apologize for not being able to attend in person this evening. It's hard to believe that the word Omicron became part of our common vernacular only 2 months ago when reports of a highly transmissible new variant were coming out of South Africa. We're learning more about how the Omicron variant differs from the Delta variant. And here are 3 ways that appear to be emerging. First is transmissibility. Omicron appears to spread more easily from person to person than many previous variants. Preliminary data suggests that the Omicron variant is up to 3 times more infectious than the Delta variant. The second is immune escape. And early evidence suggests that there may be an increased risk of reinfection with Omicron compared to other variants of concern. In addition to this, immunity conferred by previous infection or vaccination appears to be reduced with Omicron when compared to Delta, but not completely overcome. Data is showing that vaccinated individuals who either receive a booster dose or who were previously infected are likely to have a stronger protective effect against Omicron. And vaccination is shown to offer protection against severe illness and death. And finally, disease severity. Available data suggests that Omicron infection might be less severe than infection with previous variants. If you look to the graph on the right-hand side of this slide, it shows the prevalence of various variants as indicated by what's called whole genome sequence testing, which is done on a subset of samples here in Virginia. This is data for the Virginia Central Healthcare Region and shows trends in the predominance of various variant strains over time. On the very far right of the graph, you'll notice the growing proportion of samples colored purple that indicate Omicron outcompeting and eclipsing the Delta variant over the course of the last 2 months. I've circled this portion of the graph in red to simply highlight it. The CDC now estimates that over 99% of COVID-positive test results in the United States indicate infection with the Omicron variant. Next slide, please. I'm going to briefly cover COVID-19 case trends and projections. The large graph you see in the upper left-hand quadrant of this slide shows the daily case numbers for Chesterfield County since the beginning of the pandemic. So looking at this graph, going from left to right, you can see the alpha wave caused by the alpha variant 1 year ago, The Delta wave that started this past summer and that ran through this autumn, and then the nearly vertical rise in cases caused by the Omicron variant over the past 6 weeks or so. The good news, if you look to the very, very far right, is that we're actually seeing a stable and steady decline in case numbers that may indicate that we've traversed the peak number of cases. We've seen a similar peak and decline in district percent positivity rates, which is encouraging confirmation. Now, if you look at the graph immediately below, it shows the weekly death count for the county and again shows the impact of the Alpha, Delta, and Omicron waves going from left to right. On the very far right of the death count graph, I've circled in red the weekly death counts corresponding to the Omicron wave. The low death numbers relative to the very high case numbers so far seem to confirm the observation that Omicron is not causing severe outcomes like previous variants of concern. We do have a greater proportion of the population who are fully vaccinated, particularly among the elderly, which is certainly helping. But death data also tends to lag by a few weeks, so we'll have to keep an eye on this trend. I unfortunately don't have a similar graph for hospitalizations, but hospitalization utilization has gone up significantly for the Central Healthcare region, most likely because of the sheer number of people who are becoming infected by this highly transmissible variant. Finally, if you look at the right-hand portion of the slide, I've included a projection from the UVA Biocomplexity Institute. This information is available on the BDH website, and it shows a projected trend in cases if current variables remain in play. Most notably, it shows a sharp decline in cases through the month of February. The peak number of cases in this projection is expected to occur during the week of January 30th. Next slide, please. This slide alludes to information that Dr. Worsley has shared, and it relates to PCR testing offered through BDH resources. So we began to increase PCR testing capability in the middle of this month as testing opportunities became incredibly strained as Omicron cases began to soar. Rapid tests pretty much vanished from the shelves in the latter half of December and through much of the month of January. BDH began establishing community testing centers, abbreviated CTC on this slide, in various parts of the Commonwealth. As Dr. Worsley indicated, the CTC opened at the county fairgrounds on January 19th, capable of offering 500 PCR tests a day. It operates 4 days a week, which amounts to 2,000 tests per week. The health district also ramped up our PCR testing capabilities and have been able to offer 600 PCR tests per week to district residents. PCR tests currently have about a 3-day turnaround time. As you can see, demand for PCR tests have been declining, hopefully because rapid tests are becoming more available. We're hearing from retailers that the supply chain is becoming more reliable and rapid tests are returning to shelves. Next slide, please. In my final slide, I offer a snapshot of vaccine uptake in the county. This data comes from the BDH website. The numbers continue to look good, with almost 84% of the adult population having had 1 dose of vaccine. 65.5% of those eligible to receive a vaccine are fully vaccinated, and over 75% of those 18 years old and older are fully vaccinated. On the right-hand portion of the slide, you'll see a graph showing daily COVID vaccine administration for the state for the past 4 months. Statewide, the number of doses administered have dropped significantly since the beginning of the new year. I don't have similar data for Chesterfield County, but the declining trends have been true for the Rockwood Vaccination Center, with demand for vaccines through the health department's community outreach team. BDH has vaccination advertising in place, and we'll continue to monitor these trends. Thank you so much, and I'm happy to answer any questions you might have.
Board members, I have a couple questions, Dr. Samuel. First, there's, of course, a lot of discussion about masks. What kind of masks should we be wearing now and why?
Yeah, really good question. Basically, the CDC guidance says to wear the most protective mask that fits well and that you will wear consistently. So that the key is simply to wear a mask. There are recommendations based on kind of your risk profile. So if individuals are caring for somebody who's sick with COVID, if an individual is immunocompromised, if you work at a job, for example, where you interact with a large number of people, especially those who don't wear masks, consider wearing either a mask or a respirator that offers more protection. And a respirator would, qualified respirators would be items like K95 or KN95 masks. Now, respirators and more higher utility types of masks like those are probably not for everyone. So again, it depends on your risk profile, your concern about catching COVID. For situations like schools, N95s and KN95s typically need to be fit tested, certainly the KN95s, and they're not really designed for children. There are ways that children can wear double masks if there's an interest in parents for doing so, or tightening the mask that they currently wear. So really, it sort of depends on the individual and their concern.
Thank you. I just had one more, Dr. Samuel, and that is, we've heard a lot of discussion about immunity. What lasts longer, immunity from the vaccine or immunity from catching one of the strains of COVID?
Yeah, and I would still say the jury is still out. It often depends on the study or the particular scientist that kind of has an opinion about the issue. The CDC is still sticking with 90 days, although there is evidence that immunity from previous infections lasts longer than 90 days. So the short answer to that, I think, is the jury is still out. But as far as guidance is concerned, VDH is still following CDC guidelines about the 90-day immunity protection offered from previous infection as it relates to isolation and quarantine.
Thank you, Dr. Samuel. Did that prompt any questions from board members? If not, thank you. And thank you, Dr. Worsley, for this presentation.
Thank you all for having us tonight. Chief Center is next.
I believe I'm the last man standing. Good evening, Mr. Chairman, members of the board. Dr. Casey, please advance to the next slide, please. I'd like to begin my remarks this evening by commending the efforts of the men and women at Chesterfield Fire and EMS. These professionals have worked tirelessly over the past several years to serve our residents in an environment that has presented a myriad of challenges unlike any other time in the history of our department. Since the beginning of the pandemic, over 245 members of our department have tested positive for COVID, some of whom have experienced lasting side effects. Nearly 1/3 of all COVID infections in our department occurred over the past few weeks alone during the most recent surge of the virus, fueled by the Omicron variant. During the surge, we consistently hovered around 35 members who were unable to report for duty at any given time due to suspected or confirmed COVID infection. At one time, there were as many as 62 members unable to report for duty for this reason. This was all on top of up to 20 long-term absences that we typically experience on any given time for reasons including serious illness, work-related injuries, military deployments, and pregnancy. As you can imagine, the impact of having between 50 and 80 total members unable to work can be staggering in the ability to adequately staff an around-the-clock emergency services organization. Now, during this difficult time, our members have really stepped up once again on their days off, working long hours through a combination of voluntary and mandatory overtime to ensure that no career stations or response units were left unstaffed over a given shift. On days that our absences were highest, it became necessary to execute the first tier of our alternative staffing plans that reassigned individuals from our training, administration, and resource management areas to cover absences in emergency operations. Unfortunately, we've made the decision that we can no longer cover the ongoing unplanned gaps in scheduled duty crews for the Manchester Rescue Squad over nights and weekends. This will at times leave the 9th busiest EMS district in the county open on nights and weekends, which then must be covered by the 2nd, 3rd, and 4th busiest career medic units in the county. As you know, even before the pandemic, our staff has been stretched incredibly thin for many years. Despite various incremental improvements in staffing levels over the past 5 years, we remain heavily reliant on firefighters working on their day off to cover minimum staffing needs, whether it be voluntarily or under forced overtime. When such events such as COVID, flu strain, or a major incident occurs, it's very difficult to cover the resulting staffing shortages, and we must then turn around and lean even harder on the existing workforce. To give you an example, during the first half of the current fiscal year, long before the variant hit us, we had already incurred over 97,000 hours of overtime to cover minimum staffing needs. That's about 9.5% higher than the highest full year use of overtime to date, and that was back in 2019. This equates to over 22 firefighters a day on average working a combination of voluntary and mandatory overtime to ensure that all fire stations and response units are staffed appropriately. This is not sustainable in long term. We've been very fortunate recently because this is a very low leave utilization time period, January, February, and March. Had this surge occurred later in the year, we would have had some real problems and probably would have had to place units out of service. But I'm very proud of our members stepping up on their days off and making sure that all units were covered during this very difficult time. Next slide, please. In addition to working longer hours, our members on the front lines continue to experience record high call volume. Since we last met, we have attained the final figures for calendar year 2021, and fire and EMS responded to 13.8% more incidents than the prior year. That represents a growth rate higher than the past 5 years combined, so it has been a very busy year. Over 80% of those incidents were medically related, with significant drivers in this area being COVID, chronic illnesses, including those who have deferred care out of concern of contracting COVID in the hospital. And we're also seeing an increase in various problems related to more individuals aging in place at home. For example, we're getting more calls for lift assists. Elderly occupant of a home has fallen down, the spouse can't pick them up and get them back in bed. We get called to go help. They may not need a transport to the hospital, they just need help getting up. We're seeing an increase in those types of calls, for example. Collectively, higher call volume, longer EMS unit committed times, either through longer hospital turnover times, decontamination time after transporting a COVID patient, and declining volunteer participation altogether contribute to lower EMS unit reliability. Given the most recent snapshot through December 31st, the EMS unit reliability across the county has dropped to about 59%. What this means in general terms is that when a citizen calls 911 for a medical emergency, there's a 41% chance that the closest ambulance may not be available to respond and will have to come from a farther distance. While some EMS districts have fewer calls and higher unit reliability approaching 80%, key areas of the county covered by several of our volunteer rescue squads, including Manchester Volunteer Rescue Squad on Courthouse Road and the Forest View Volunteer Rescue Squad in Midlothian, have 38% and 3% reliability respectively. If current incident trends continue, we anticipate a growth rate of about 10.9% by the end of the current fiscal year and a growth rate of 6.5% by the end of the calendar year. As we look farther ahead over the next 5 years, COVID has really blurred what the outcome may be. It's very difficult to give you a firm estimate of what we believe will be a sustained growth rate in the future, but we still expect to see a fairly aggressive increase in call volume over the next 5 years when you take in consideration the development and growth that's happening in the county, and more importantly, the continued increase in the number of residents who are 65 years of age and older. Next slide. Finally, no discussion about COVID would be complete unless we include a discussion of the ongoing challenges experienced by the hospitals across the nation and right here at home. Hospitals are indeed seeing an increased number of COVID patients, as Dr. Samuel mentioned earlier, as well as other patients requiring long-term intensive care. Hospital emergency departments also continue to see many patients with lower acuity needs that could probably be handled through other resources. On top of all of this, hospitals are experiencing staffing shortages due to retirements, nurses pursuing higher paying jobs as travel nurses, those who transfer into more stable clinical settings such as medical practices, and those who have left healthcare professions altogether. In talking with hospital administrators, the staffing situation is not likely to drastically improve anytime soon. There's also a very real concern about a shortage of nurse educators and nursing students who will be needed to meet the needs of the growing number of older patients well beyond the pandemic. In the interim, we continue to collaborate and coordinate with our area hospital systems and our regional EMS council, and Chesterfield Fire and EMS assumed a greater leadership role in this effort. Battalion Chief Adams and Dr. Yee continue to actively participate in the Regional Hospital Diversion Committee, and Deputy Chief McKay has recently been elected to serve as the chair of this committee. Previously, hospitals had a very heavy presence in this committee, and now EMS is taking much more of a lead in that effort. As you may recall, the hospitals in Central Virginia have been in Code Black status since August in accordance with our Regional Hospital Diversion Plan. This essentially means that 8 or more hospitals are in diversion in the region, and a patient destination center, or PDC, is activated to direct ambulances to the closest hospital that can handle their patient. Our regional diversion plan and the use of the PDC was intended for a short-term event that overloaded hospital capacity, such as a mass casualty event. It was not designed for long-term operations, and it is not sustainable and will likely discontinue operating as soon as this weekend. Furthermore, we found that approximately 90% of the time, the patient was routed to his or her hospital of choice by the PDC. And even under the PDC's direction to a specific hospital, our crews at times have been met with hours-long patient turnover times. The PDC is not sustainable long-term, as I said, and is likely to be discontinued as early as this weekend. And in advance of this change, we are engaged in a pilot program over the next several days that essentially cancels all diversions, and we will then transport patients to the closest appropriate hospital consistent with the patient's choice. I'll follow up with you all later in the weekend on the results of that pilot study and let you know what the next steps are. Just as we've done for the past 6 months, our shift commanders and battalion chiefs will continue to monitor patient turnover times, and when a hospital has not accepted a patient after 45 minutes, the crew will take steps to safely offload the patient consistent with guidelines established by our medical director and consistent with federal law. What we cannot have is all of our ambulances getting stuck at the hospital and having a greater need in the community that we cannot respond to. Other short-term actions to address the staffing challenges in hospitals include the governor's recent executive orders that relax some of the regulations related to bed capacity and staffing requirements and allows broader use of related professions in a hospital environment, as well as allowing nurses certified in other states to practice in Virginia. Finally, in collaboration with other area fire and EMS chiefs, there may be some opportunity in the future for PSAs to better educate the public on the current challenges and what they should expect in the event they call 911 for a transport to a hospital. That concludes my part of the presentation. I'll be happy to answer any questions that you may have.
Questions, board members?
Just a comment, in terms of the PSAs, I think that's an excellent idea to have that shared with the community, because it's my understanding our health community is really stressed, our hospitals are, and so you being on the front line would be stressed as well. Have you seen an increased need for counseling for those who are under health duress, stress in the community? Have you seen it, Chief?
Yes, I don't have any numbers with me this evening. I can certainly follow up with you on that, but I know that our MIH program is actively involved in a lot of different cases out there, and certainly there are a lot of mental health needs. We work with our partners at Mental Health Support Services to get those folks the needs that they have. We also see some of those patients come through our 911 system as well. I'll try to get some information and get that back to you as well to let you know how that stands right now.
Thank you, Chief.
Yes.
Mr. Engel?
Chief Center, I know it's mostly a COVID update, but this relates in to a certain extent. The pulse point that you're putting out,
Yes.
do they have, which is basically anybody that's CPR certified can sign up to get an alert, and if somebody's having a cardiac issue in the area, you'll be notified that somebody in the area is getting that, or is having that. But do they have a way to respond to let you know that they're going to help?
No, currently with this particular app that we have, there's no way for anyone to engage back with us to let us know that they are responding.
So I don't know if there's a way to do that, but I was thinking that there may also be people that are willing to respond to some of the calls for assistance for an elderly person that just fell out of the bed. And maybe we could look at a program like that as well that maybe they would go over and assist people get back in bed so we don't have to type an ambulance to do that. Because
Well,
that was a great program that you put in place with
Right.
Pulse Point.
We have to be very careful about that. The Pulse Point app, lets people know that there's an incident in a public setting that's nearby. When you send someone into someone's home, that's a wholly different situation. And so there's a lot of other things. I mean, essentially, we would be looking for volunteers, which we're already having a challenge recruiting and retaining in the volunteer
I
system.
just thought
So-
maybe if all they had to do was go help somebody get back in bed, that there may be some people that would be willing to do that. But I understand the challenges associated
Yes,
with it.
and also at the point of sending a resource over from Fire and EMS, we do a patient evaluation on them, make sure that they're not injured. Sometimes people say, oh, I just want to get back in bed or whatever, or I just need help up, and we find out that they are injured, and we might recommend that they do go to the hospital at that point. But your point's well taken. I don't know that we have an easy fix for that. It's one of those things that we're going to have to think through, and certainly we'll have some more discussions with all of you as we go forward with the aging population and the larger number of those that are 65 and older in our community.
Chief, first, congratulations to Chief McKay on that new role. And also, when does the Midlothian station and the associated ambulance there come online, or is expected to come online?
So we've just hired the 20 new positions that the board approved this fiscal year. They've already started recruit training. They should graduate in July, probably mid to late July. The fire station, we're expecting completion sometime late summer, early spring. So it may go active with just the fire engine. So once we have the 20 new positions graduate, distribute to the field, and we move the new people that will be going, or it's not new people, but we reassign people going to the new Midlothian Fire Station, then the ladder truck, which we've also just recently taken delivery of, that will go in service, as well as the ambulance. They'll both be ready, and that'll be a welcome addition to the Midlothian community, much improved service in that area.
I might have to try out that bucket.
We'll set you right up. I thought about you the other day. We had the new ladder truck over here at our RMD division, and we were looking at it and operating. It's very nice.
I've been pushing out the pictures. It's very exciting. It's very
It
exciting.
is.
They tell me it's a little different, though, than
It
the
is.
one that I was up
It
in.
is.
So
It's uniquely designed to fit in these more dense urban areas and more
Right.
dense environments that we're seeing. So,
thank you.
all right.
Thank you, Chief.
Thank you all.
Appreciate you.